Welcome, everyone. Thank you for joining us. My name is Dr. John Baker. I am an interventional cardiologist in Orange County, California, and I am co-chair of um, the the cardiovascular committee for prevention committee. So I'd like to welcome you. We have our two speakers today. Dr. Wong is going to be the moderator, and Dr. Fonero is going to be our guest speaker. I'll have them introduce themselves in one moment. As far as the format, there's going to be a chat in the lower left corner. So if you see chat in the lower left corner, that is something that you can use to do chat within this, so you can ask questions at the end. We will have time for Q&A at the end of the session, so that's going to be at the end of the session, so you'll have a chance to answer questions. In addition, when you yeah, so that's basically it for the format. So without further ado, I'm going to introduce first Nathan Wong, who's the co-chair of the cardiac ACC, or the California ACC Prevention Committee. So Dr. Wong, and he's also the chair of the prevention section in UC Irvine. So Dr. Wong.
Well, thank you very much, Dr. Baker. It's wonderful to have you all on with us today, and I see some familiar faces, so that's really great. And it's really our honor to have Dr. Greg Fonero, who I've known for at least 25 years, and he's always been so gracious to present to my class and other as well as other settings. He recently gave cardiology grand rounds to us at UCI as well. So Dr. Fonero has been for many years the Elliott Corday Professor of Cardiovascular Medicine and also director of the Amundsen UCLA Cardiomyopathy Center and co-director of UCLA's Preventive Cardiology program, and he is certainly needs little introduction, so I'm not going to delay it too long, but just briefly to point out, he's certainly one of the key international experts in acute and chronic heart failure, preventive cardiology, and many other areas. And he really has um, uh, he did seminal work involving implementation of actually guidelines, not just for heart failure, but also coronary artery disease. And I first knew of him when he championed, I think started in his residency, the UCLA CHAMP program, which really served as a model for AHA's development of its well-known Get With the Guidelines program, which he was key in helping to develop as well. And he's been involved in countless clinical trials and large-scale registries that he's chaired, including ADHERE, Optimize Heart Failure, and Improve Heart Failure. He has close to 800 or 1,000 publications. I've kind of lost count, and has gotten numerous awards. So with that, I'm going to turn it over to you, Greg, and he's going to talk on prevention of heart failure, which is really a very important topic and very relevant for our California ACC Prevention Committee. So I think everyone can see his slides, and we'll save the Q&A for the end. And so take it away, Greg.
Great. John and Nathan, thank you so much for this opportunity. Thank you all for joining us this evening, and delighted to present on this topic of prevention of heart failure, something very passionate about and have worked hard on. Here are my disclosures related to this presentation. So, as you know, heart failure is really common, and once it develops by its natural history, very deadly and economically incredibly costly. There'll be about 1 million new cases of incident heart failure this year in the United States, and more than 10 million worldwide. the prognostic impact of having new onset heart failure is profound. Individuals developing heart failure compared to the general population will lose 10 to 15 or more years of life. And over the last 20 years, there's been relatively little improvement, at least at the population level. So the idea and the hope is by better identification of individuals at risk and the mechanisms by which risk factors lead to heart failure, we can have better heart failure prevention, thus have a meaningful improvement in population health. And so, a key point that I will be making throughout this lecture that heart failure is eminently preventable, but there are so many missed opportunities. And if we took advantage of those, we could dramatically reduce the incidence and morbidity and mortality due to heart failure. So what do we mean by heart failure? There have been various definitions over the year, but just to level set, when we talk about heart failure, this is a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection of blood. You're all familiar with the cardinal manifestations of heart failure, but it's really important to recognize there are multiple disease states that ultimately result in this clinical syndrome of heart failure. But the key is, again, this is entirely preventable. Now, once somebody develops heart failure, it's worth recognizing the tremendous burdens. I mean, compared to having chronic coronary disease, where, maybe there's some angina that exists, most of these patients have very good quality of life. When you look at heart failure patients, their quality of life and health status is as poor as patients with metastatic cancer. They have congested symptoms, markedly impaired health status, activity and functional limitations, dysrhythmias, hospitalizations and rehospitalizations, and as I mentioned, this markedly reduced survival. We want to do absolutely everything we can to prevent heart failure. Yes, we have a variety of treatments and can extend life, make patients feel better, but preventing heart failure is absolutely critical. So what's the lifetime risk of heart failure? It's incredibly high. You make it to age 40, and then over the rest of your life for men and women, the risk is 1 in 5. So somewhere around that 21, 22%. This has held steady for approximately the last 20 years. And there are certain subgroups by race, ethnicity, or socioeconomic status where that risk can be as high as 1 in 4. So the lifetime risk for developing heart failure is very high. So what's the consequence? This is actually work we generated from AHA's Get With Guidelines. But look for, compared to the general population, somebody develops incident heart failure, regardless of ejection fraction, so reduced, mildly reduced, preserved EF. You can see even for individuals 65 to 69, develop heart failure, that median survival only in the 3.3 to 4 year range, compared to the general life expectancy in that age group where it's 18.7 years. So you're losing more than 15 years of median survival. Even for somebody who makes it to age 90, you develop heart failure, it's a median survival less than a year compared to 5 years for the general population. So again, we want to do absolutely everything we can to prevent heart failure from developing. Now, about 20 years ago in the guidelines, the ACC and AHA developed a staging system for heart failure, and the rationale here was to borrow from oncology to make the case that heart failure is preventable. We can identify those at risk for heart failure, call it stage A, because they've got risk factors, and we can prevent them from going on to develop structural abnormalities of the heart that makes them at further risk for heart failure that's now referred to as stage B and pre-heart failure. And then of course, stage C is our classic symptomatic heart failure, and stage D are those that are refractory despite medical therapy that need advanced therapies like transplant, LVADs, or if not a candidate for those, consideration of palliative care. So we recognize there are risk factors and structural prerequisites to developing symptomatic heart failure, and we want to identify those individuals and proactively prevent heart failure from developing. Now, once symptomatic heart failure develops, there are trajectories where, you can have the new onset heart failure, persistent heart failure, worsening heart failure. But we're really talking about and focus the best way to address the trajectory of stage C heart failure is preventing it from developing in the first place. Now, symptomatic heart failure, in a sense, is the tip of the iceberg. Those with stage B, that used to be referred to as asymptomatic LV dysfunction. So whether systolic or diastolic dysfunction, these individuals have underlying structural abnormalities that put them at great risk for symptomatic heart failure. And we recognize there are many more of these individuals than those that have overt symptomatic heart failure. And these individuals, if we intervene, even when there's structural abnormalities, and prevent the onset of symptomatic heart failure, we can markedly alter their natural history and improve prognosis. So in the US, what are the major risk factors for developing symptomatic heart failure? Well, the two major ones and most modifiable are ischemic atherosclerotic cardiovascular disease and hypertension. A growing contributor is obesity, diabetes, metabolic syndrome, smoking dyslipidemia, valvular heart disease, very important, but a smaller component. And it's now been increasingly recognized chronic kidney disease and microalbuminuria can contribute to heart failure risk. So there are a whole host of other ones, genetic abnormalities, chemotherapy, other things that we can talk about, but these are the major population attributable risk factors that drive the majority of heart failure in the United States. So from the guidelines, they highlight the risk factors of hypertension, obesity, prediabetes, diabetes, and ASCVD, and describe the various mechanisms by which this can go on to lead to left ventricular dysfunction and ultimately symptomatic heart failure. But the key for highlighting this is we can intervene at these steps of the risk factors to prevent going on to develop stage B and stage C symptomatic heart failure. So here's a scientific statement back in 2008 that I was on the writing group for, where we began to define those major and minor risk factors for developing heart failure as well as other causes here. But what's most notable here is throughout all of this time, there has not been dedicated guidelines around prevention of heart failure, the way that we've had 20, 30, 50 plus prevention guidelines focused on atherosclerotic cardiovascular disease. Well, you can say, hey, that's far more important than heart failure, except you've missed over the last 20 years. There are far more deaths now due to chronic heart failure than acute myocardial infarction by a fourfold factor. So we've missed, by not focusing intensely on prevention of heart failure, that incredible burden that has developed, because we've had tremendous success with some of the prevention of ASCVD as well as treating acute myocardial infarction. So I'm going to summarize quickly a variety of different epidemiologic studies that have done in the US and worldwide that look at what are the independent risk factors for incident heart failure. And the various studies have various risk factors, but you'll notice many things are in common there. So of course, age, atherosclerotic vascular disease, hypertension, limited physical activity, smoking, obesity are major drivers across the world that we see for incident heart failure. So here's a classic Framingham study looking by men and women, the age and risk factor adjusted hazard ratio. You can see hypertension, myocardial infarction, diabetes, big players. And then when we look at the population attributable risk, then hypertension by far has the largest contribution there, followed by MI, followed by some of these cardiometabolic things such as diabetes. So, and obesity has emerged even greater since this study was done. So this is data actually showing there was a lot of debate. People recognize, well, individuals with obesity, they develop heart failure because they develop coronary disease or develop overt diabetes. But in fact, you can see that obesity and being overweight in of itself in individual men and women are independent risk factors for incident heart failure. And so we've had a marked increase in the prevalence of overweight and obesity in the United States and worldwide, a major driver for why heart failure incidence has continued to rise. So for our individuals at risk, these big risk factors, do we have evidence that if we modify these risk factors, we can actually prevent heart failure? So that really becomes critical here in this regard. So we do have some data with regards to these issues of physical activity and risk. And so if you compare those who are physically inactive to those who are active, we also see a lower risk of heart failure, and you can see this in a graded fashion. So physical activity is also a major risk factor. This was analysis Donald Lloyd Jones and colleagues looked at. So looking at healthy lifestyle risk factors, not for ASCVD, but for incident heart failure. And we see compared to those with none of the healthy lifestyle factors in a stepwise fashion with 1, 2, 3, or 4, that we get the lower risks with regards to risk factors there. So we really can have a favorable impact in this regard. So now let's look at what the guidelines kind of say. They say we should try and detect individuals that may have any signs or symptoms for heart failure routinely in our evaluations. And if you're all suspecting heart failure, then getting an echocardiogram and looking at the parameters, including LVEF, is critically important. So what are the recommendations regarding stage A pre-heart failure for therapy? And we're going to go through the evidence that support these. But as you imagine, then treating hypertension, encouraging smoking cessation, treating and preventing lipid disorders, regular exercise, discouraging alcohol intake, controlling metabolic syndrome, treating obesity, and then there'll be specific drugs. So let's go through the data with regards to prevention and treatment of hypertension and how that translates to preventing heart failure. Turns out if you look at individuals with heart failure, 60 to 80% of them will have a prior past medical history of hypertension. So, absolutely matching that population attributable risk that I showed you. And trial after trial after trial shows you that treatment of hypertension, the major modification of risk that occurs is actually preventing heart failure, much more so than stroke, MI, or chronic kidney disease. Lower is even better, and how we actually treat the hypertension may matter to a certain degree. So if we go back to some of the original landmark trials regarding treatment of hypertension versus placebo at a time where people debated whether treating hypertension was beneficial, you can see these remarkable risk reductions in new onset heart failure, fatal and non-fatal. In SHEP, it was a 49% relative risk reduction. In CIS-EURO, 29%. In a meta-analysis of 12 randomized controlled trials on the impact of blood pressure reduction, it's illustrated here. Stroke risk reduction, relatively 38%, coronary heart events, 16%, and heart failure, 52%. So this dramatic reduction. Yes.
Can you reshare your slides? Just hit the share button on your thing. The slides kind of went off for a minute. Sorry.
Yeah, did we?
Yeah, that's okay. Just hit reshare. We can get your slides back up.
Thank you for pointing that out, because I couldn't see it on my end.
Yeah.
Are you seeing them now? Do we got them? John, you're on mute. Can you see him, Nathan?
Yeah, excellent.
Yes.
Slides
Oh,
are
great. Okay,
Yes.
thank you.
Good to go. Thank you.
All right, so here was a slide showing those risk reductions. And this is now a really classic study because even after all those trials, individuals debated for those who were older than year 80, whether treatment of hypertension in those individuals would still be worthwhile. So this is the HIVET study. They looked at treating with a diuretic plus minus ACE inhibitor in older patients, hypertension VA setting versus placebo. So you can imagine still debate. Trial stopped early, and there was a reduction in fatal, non-fatal stroke that almost reached significance. There was less mortality, less death from stroke. But what was driving that difference in mortality? Look at new onset heart failure risk here. Began within weeks, separated to this massive degree, p less than 0.0001, 64% risk reduction in new onset heart failure in these older individuals in treating their hypertension. So absolutely phenomenal benefit. Now, this issue of, is it fine to just treat to 140 over 90, or would treating to a greater degree provide benefit? Well, analysis of the study certainly showed the greater the reduction in systolic blood pressure from baseline, the greater the risk reduction. But that's not the same as just showing targets. Now, the original more versus less intensive blood pressure control didn't have heart failure as an endpoint and missed some of this benefit. But the SPRINT trial integrated in the cardiovascular composite heart failure. So these were close to 10,000 individuals that had a history of ASCVD, no history of diabetes or stroke, randomized to a usual target of aiming for 140 or aiming for 120 or less. And importantly, that primary composite endpoint included heart failure. Trial achieved a nice separation. Noticed in the standard treatment group, they got systolic blood pressure below 140, was kept at about 136, 134 throughout the trial. Aimed for 120, got very close at 121. So it's about a 15 millimeter difference in blood pressure between the two groups, meant a difference between being on an average of 2 meds versus an average of 3 meds, and maintained over the 5 years of follow-up. And we see for the primary endpoint, 25% risk reduction. But look at MIs, not much different. Stroke, not much different. But look at heart failure. This incremental, remember, the group reduced in usual care was more than a 50% reduction, new onset heart failure. Now, on top of that, an incremental, additional 38% relative risk reduction, highly significant. This is fatal and non-fatal heart failure, and this drove a reduction in CV death and all-cause mortality. So phenomenal incremental benefit of going for more intensive blood pressure control. You can see in acute decompensated heart failure outcome by treatment group this dramatic reduction, and seen very early on where these event curves are separating. And you can see the impact of how this played out. You prevent new onset heart failure. Those that developed acute decompensated heart failure at some point during the trial, what was their subsequent mortality risk? Death from cardiovascular cause, a 27-fold higher difference. So, compared to other things that happened, and for all-cause mortality, a 10-fold difference. So preventing incident heart failure in our patients' hypertension dramatically played out for mortality risk reduction. So guidelines embrace this. Picked a pragmatic sort of less than 130 and less than 80 for the treatment target, but for carefully measured blood pressures, similar to SPRINT, that 120 over less than 80 goal really sort of holds. So we've got overwhelming data treating hypertension prevents heart failure, treating intensively prevents even more heart failure. What about lipid management and prevention of heart failure? So about 50 to 80% of patients presenting with heart failure in the US have a history of coronary disease. And so do we have evidence that, preventing treating coronary disease with therapies such as statins translates to benefit? So the overall landscape of primary, mixed, and secondary prevention studies focused on cardiovascular events where we get a 25 to 38% risk reduction. But what about heart failure events? And what you can see is that, even back to the FLORES study, there were 24% reduction in heart failure. Now, when you look at whether there were intercedent MIs that occurred between the development of heart failure, in some cases there were, but in other cases you were preventing heart failure where there was not an antecedent, at least clinically recognized acute coronary event. And so statin therapy in those with atherosclerotic cardiovascular disease to prevent events. Now, you also know more intensive lipid-lowering therapy compared to standard dose reduces overall cardiovascular events here, coronary death and MI. But what is underappreciated in these same trials of high dose or standard dose statin therapy is the reduction in heart failure risk. So here are the same 4 trials, but now looking at heart failure endpoint and a 27% risk reduction, highly statistically significant. So for those with known ASCVD or an ACS event, high intensity statin not just prevents recurrent atherothrombotic events, also helps you effectively reduce their risk of incident heart failure or heart failure deaths. So really, really important in our stable CAD or ACS population to apply the therapy according to the guidelines, getting the benefits of less MACE, but getting the benefits of less heart failure. The other thing I also want to highlight for primary prevention, even those people who have average LDLs of 100, as we saw in the Jupiter trial, use of 20 of rosuvastatin versus placebo there were reduction in cardiovascular events, including heart failure. And, in this Jupiter analysis of those who were on statin and got their LDL to less than 50, if you look at, so they were adherent to statin therapy compared to placebo, and look at these composite event rates, including in heart failure, were all markedly reduced and overall was well tolerated as placebo. So aggressive primary and secondary prevention with lipid-lowering therapy is markedly beneficial. Now, what about ACE inhibitor therapy beyond, blood pressure control? This is the HOPE trial, so diabetes or stable ASCVD, and you saw less MI and stroke, so that's all good. But here I want you to focus on the reduction in risk in heart failure, 23% relative risk reduction as well as mortality. So this can make a case, even if blood pressure is well controlled, you have ASCVD or have type 2 diabetes, routine treatment with an ACE inhibitor can prevent new onset heart failure. Now, people remember the PEACE trial and view this as sort of a neutral trial and took the point, well, if patients were revascularized and had normal LV function, maybe they don't need an ACE inhibitor. Well, that may be true if your outcome that you care about is only MACE. But if you care about preventing new onset heart failure, then you'd say, no way in the world would I not apply an ACE inhibitor, because there was about 25% risk reduction, highly statistically significant with routine ACE inhibitor in well revascularized patients, who were on statin treatment and other risk factors well controlled and were not hypertensive. So even in those patient population with atherosclerosis, we can prevent new onset heart failure. And we have similar data for those with type 2 diabetes. This is Renau looking at losartan to prevent chronic kidney disease, but its greatest benefit was a 32% risk reduction in new onset heart failure. So we have the power with routine use of ACE inhibitor ARB therapy, even if LV function is normal, even if blood pressure is otherwise well controlled, even if they're not otherwise indications, the use of an ACE inhibitor ARB can prevent new onset heart failure. So we've got some nice guideline recommendations that say this with regards to preventing new onset heart failure. If you look at MACE, they get a little softer and leave it as more optional in the absence of LV dysfunction. Now, what about obesity and heart failure? So I showed you the data, obesity increases the risk of heart failure. It is interesting how important this is. If you look at those with BMIs 30 and above, they develop new onset heart failure about a decade earlier than those who are in the healthy weight category. I mean, that's pretty stunning in that regard. Now, what about intentional weight loss? Well, we didn't really have that data until recently, but now we do. So this is a SELECT trial. These are patients with ASCVD, an elevated body mass index, randomized to semaglutide versus placebo. The overall trial was positive, and even there was a reduction in CV and all-cause mortality. But here is pre-specified heart failure composite, and there was an 18% relative risk reduction relatively early in heart failure events. So we can see CV death or hospitalization or urgent visit for heart failure by treating obesity with the GLP-1 receptor agonist that we can prevent new onset heart failure in these patients. So here is definitive and very helpful data. Now, of course, we've got remarkable data that once you have heart failure with mildly reduced or preserved EF, we now can prevent heart failure events and improve functional capacity. Here's STEP heart failure preserved EF with and without diabetes and time to first heart failure event. And you see this remarkable risk reduction. And we also have this in the SUMMIT trial, CV death or a heart failure event with the dual incretin inhibitor as a co-primary endpoint compared to placebo, this 38% risk reduction in those with obesity and heart failure with preserved EF. So a treatment in those patients as well as an ability to prevent heart failure. So this is remarkable. We've added to our armamentarium in a real way. Diabetes and heart failure markedly increased risk of heart failure in those with type 2 diabetes, 2 to 4-fold increase. Developing heart failure in a patient with type 2 diabetes increases their mortality 10-fold. We clearly want to prevent, in fact, it's worse to develop heart failure if you have type 2 diabetes than to develop a myocardial infarction. But we were handicapped because our glycemic control strategies, although tested to see if they could prevent heart failure, were failing right and left, and even some like TZDs actually caused heart failure. So, we felt horrible. Patients' diabetes increased risk of heart failure, and we had no way to actually prevent that. So here's the data with the PPAR agonist, where you actually saw an increased risk of new onset heart failure. DPP-4 inhibitors were thought like, oh, they're going to be great for preventing heart failure, if anything, an increased risk. If we look at, intensive control versus less intensive control in ACCORD and ADVANCE, neutral for heart failure, insulin neutral, even look ahead, intensive lifestyle modification didn't lower heart failure risk. So wow, pretty incredibly disappointing. And then, here's ACCORD, intensive glycemic control, fatal and non-fatal heart failure, the hazard ratio 1.18. So then the SGLT2 inhibitors came along. People didn't have much hope for this. They thought hopefully they'll have cardiovascular safety. In the first large trial testing this for cardiovascular safety, heart failure was not a clinical outcome. It was a secondary safety endpoint, which they thought would be neutral. But here's the EMPA-REG outcome study. The primary composite reached significance, but there was only, a really modest reduction in MI or stroke, but this tremendous reduction in CV death. And they looked at why that was, and it looked to be heart failure deaths. So they then retroactively constructed a heart failure hospitalization or CV death or heart failure hospitalization or heart failure death endpoint, and remarkable early benefits sustained throughout the trial. And it was like, wow, what is this? Our patient with type 2 diabetes, we can prevent new onset heart failure or recurrent heart failure. Here's the data, those without heart failure at baseline, the 10% or so that did have heart failure at baseline, uniform reduction, that was great. So all the trials scrambled to now test SGLT2 inhibitors as a way of preventing new onset heart failure, CANVAS and DECLARE, and you can see this marked risk reduction in heart failure events occurring with the use of SGLT2 inhibitors. So compared to even GLP-1 or DPP-4, this remarkable benefit with regards to new onset heart failure with SGLT2 inhibitors. And if we look at SGLT2 inhibitors as a treatment to block chronic kidney disease and DAPA-CKD, lots of nice things going on, but look at the secondary outcome of CV death or heart failure hospitalization, 29% risk reduction. So chronic kidney disease, give us SGLT2 inhibitor, you can prevent new onset heart failure, as well as mortality, as well as blocking progression of chronic kidney disease. But all our patients with CKD should get an SGLT2 inhibitor. And then, of course, testing this with or without diabetes as a treatment for heart failure and DAPA-HF, we see reductions in events that were similar. The meta-analysis of this, heart failure preserved EF, we see the benefits of SGLT2 inhibitors. And here's DAPA-CKD, and again, preventing heart failure events. So SGLT2 inhibitors, all these settings, including even post-MI, CKD, type 2 diabetes, you can prevent new onset heart failure. So putting this all together, we now have this remarkable set of risk factor modification and therapy that can dramatically reduce the risk that adults 1 in 5 are at risk for and don't appreciate that risk, haven't seen guidelines focused on the prevention of heart failure or campaigns anywhere near like they've seen for atherosclerosis. And so, ways of communicating the ways that individuals can effectively reduce risk to clinicians, primary care, cardiologists, and others involved in the care of diabetes, chronic kidney disease, as well as individuals of all these steps that they can take is critically important. Here from a cardiology patient page that Tamara Harwich and I co-authored, that we really need intensive education at all levels regarding our ability and power to actually, if we better implemented these therapies, we could prevent heart failure. So, this kind of holy grail would be, wouldn't it be nice if we had a simple little test that could tell us that somebody's at risk for heart failure, then we intervene, and before they develop incident heart failure, we actually prevent that. And, people have looked at a whole variety of different ways of doing this. But, the natriuretic peptides in the general population, not to diagnose heart failure, but just looking at here in Framingham, those in the highest tercile of BNP levels, well below the 100 cutoff, they actually were at markedly higher risk for developing new onset heart failure, more so other types of events. And so it raises that issue if you, screen a general adult population, find those with, say, a BNP or the equivalent of N-terminal BNP above 50, and then refer them to get an echo, see a cardiologist, modify their risk factors. Could we prevent new onset heart failure? And so that was the STOP-HF trial, routine PCP care or BNP directed care. If the BNP was above 50, do this multidisciplinary risk management on them. And could you prevent new onset heart failure? And there's the answer, yes. And so, that kind of unbelievable thing that we've rarely shown, that you take a biomarker, you act on it, and it actually translated to improve outcomes. Wow. And there it is. So it's a 2A guideline recommendation in the 2017 and 2022 guidelines. BNP blood test costs $20 to do. And yet, despite the evidence, despite the guideline recommendations, almost nobody knows about this and nobody's doing it in clinical practice with rare exception. Whereas systematically, if we implemented this, we could detect a large number of individuals at risk and cost effectively and highly effectively prevent their new onset heart failure risk. Other ways we can detect individuals at risk. This is the PREVENT risk score. It was released by the AHA. People think of this, it can detect, the risk of ASCVD. They remove race from the equation. They've got some emerging risk factors. But what I want to highlight for you here is you can look at and calculate exclusively the risk of heart failure using these validated models and get that risk at 10 years as well as 30 years, the lifetime risk. And you can look at overall CVD that includes ASCVD and heart failure. So this is available now. Hopefully we'll get embedded EHRs, their apps available. And so you can enter these risk factors as well as potentially others that are optional, social determinants of health, microalbuminuria, and others, and determine your patient's 10-year and lifetime risk of heart failure and use that to be better inform the expanded ages of 30 to 79. And this calculation of the absolute risk can then help clinicians and patients in shared decision-making. So available to everybody, here's the website, and hopefully coming to an EHR and risk calculator online and apps near you. But importantly, actionable for heart failure and prevention. The AHA did release this nice scientific statement. I applauded the pillars of prevention of heart failure, and this is great, came out this year. But again, where is our primary prevention guideline of heart failure, at the equal weight and getting the same attention as our hypertension guidelines, our cholesterol guidelines, our overall primary prevention of ASCVD guidelines. I think we need the similar sort of intensity and effort in that regard. But the key is between lifestyle and the specific therapies we've started, we can effectively eliminate up to 80% of the heart failure risks. So to summarize, here are the 2022 guideline recommendations for stage A, covering and summarizing the things that we've just talked about. Once you're at stage B, specific therapies targeting that left ventricle and building upon all those parts of primary prevention and continuous lifestyle modification and management strategies in stage A through stage B and on to stage C. So why is this so important and why have I put the emphasis on this? I'm now going to share something that was involved in this publication, but if this doesn't knock you out of your chair, you're not completely paying attention. And this is looking at heart failure related mortality in the US from 1999 to 2021. Now recognize this is not, the treatment of heart failure. This is the composite of how well we prevented heart failure from occurring, and then once incident heart failure, how well we prevented mortality. So it's all of those things together, the risk factors, ultimately incident heart failure and mortality. And, we were pretty happy. From 1999 to about 2011, we were seeing this nice decline in age-adjusted heart failure and mortality. Thinking our efforts of implementation, risk factor control were really going great. And then you can look at about 2012 and things start heading in the wrong direction. You say, hey, obesity started to increase, there were more diabetes, maybe some gaps around, treatment of those with established heart failure, the hospital readmission reduction program, all kinds of things going on, but continue to rise. And then of course, COVID came and boom, you look at where we were in 2021, our age-adjusted mortality rates were way back where we were in 1999. Of cardiovascular deaths, heart failure, we're now 45% of the total, fourfold the mortality risk of what we see with MI. And this was true regardless of age, including those less than age 45. Look at how age-adjusted mortality took off for them, for men and women, regardless of race, ethnic group. I mean, this is devastating. If you believe professional societies are making meaningful impact on population health and all of our research and implementation efforts are paying off, and you see data like this is like a 5-star alarm that we need to take seriously, the prevention of heart failure as well as treatment once there's incident heart failure. Now, since 2021, it started to tend down a bit, but we're still back to where we were in maybe 2022. So we've got tremendous work that we need to do. So prevention of heart failure, we can identify those at risk. It's a huge number. We've got this actionable data that we need to act on. And if we did 80% of that attributable risk of heart failure related to these risk factors could be prevented. So we need to really all pull together, working together collaboratively at the population level, the community level, the health system level, and with our individual patients to do everything we can to prevent heart failure. So economic burden continues to grow. One of the single most expensive and deadly healthcare problems we face. There'll be over 1 million new cases of heart failure this year, yet heart failure is entirely preventable, and the early modification of risk factors can reduce that risk of heart failure. The recommendation of appropriate medical interventions for patients with these risk factors, along with lifestyle modification at the earliest opportunity, can have the largest population and individual health benefit. So hope this has been helpful, and I'll be delighted to answer any questions. Thank you so much for your attention this evening. And I'll leave you with this quote. I think I first borrowed from Nathan about, us advanced heart failure physicians, we're sitting waiting till the disease is full blown. The mediocre physician is, when it's clinically manifest, but let's all be superior physicians and prevent heart failure before it even occurs. Thanks so much.
Thank you so much, Greg. This an absolutely inspiring talk. And I actually think it was the other way around. I borrowed that slide from you when you used to show it in Chinese, and you also had the had the tiger get with the guidelines or get eaten. You need to show that one again.
Yeah.
But anyway, that was really wonderful. We can start our discussion period. I have one question. I'm happy that you brought up the prevent risk score and the importance of perhaps implementing that in our electronic health record. Now, do you foresee, I don't think it's happened yet, but do you foresee future guidelines taking a similar approach that we have with ASCVD, such as where, like if you're 20% or greater risk in 10 years, you should be on a statin therapy. Do you see something like that going with the prevent heart failure score, like if you're 20% or greater, or you should be given an ACE inhibitor or considered for a, SGLT2, even since they're hopefully moving towards being generic. So just wanted to pick your brain on that, and we can take other questions.
So great. First, the AHA just announced they're sharing the source code with the EHR vendors or any health system that wants it to embed the prevent risk score. That was announced this week. So that is great news. Second, I do think guidelines like the hypertension guidelines, you're going to see that kind of risk prediction for more intensive therapy. I think that's a reasonable option, but it also gives me a little bit of caution. Our experience with the pooled cohort equation and, risk-based treatment algorithms have not necessarily translated to the kind of implementation we would hope for. That I think communicating that to individuals, like what does that risk mean? Oh, my 10-year risk is this amount. Is that high or low? Oh, I'm treating my risk number, or am I treating a risk factor? I can understand my blood pressure is high. I want to bring that down. Oh, there's a medication to lower my heart failure risk that's targeting my diabetes or my chronic kidney disease. So I think we need to proactively test the different strategies. I find the biomarker approach, well, you get a BNP if it's above 50, and we could use some other high sensitivity troponin or otherwise. And they're saying, hey, this marker shows you a risk. It's like your hemoglobin A1C or a blood pressure level. And we're going to target that, bring it down, but lower your risk of new onset heart failure by targeting this identified risk with a simple blood test. Or we're going to just say, look, by virtue of this risk factor, we're going to give you these additional meds. I don't need to know anything about your absolute risk to know that I want to lower your relative risk by 80%. So I think a composite of these different types of approaches, there's somewhere by virtue of what they have, type 2 diabetes or hypertension or otherwise, to where it would say, let's go all out. And I think when we come to heart failure, taking a 5-year risk or even a 10-year risk is not taking the longer term risk horizon we really need to think about it. You don't want to have heart failure at any age, right? So it's not like, oh, I made it from 40 to 50 or 70. I showed you. I mean, even when you're 90, you don't want that new onset heart failure. You want those 4 additional years of median survival, many of which, are quality years. And so I think we need to take that longer term horizon approach. At no stage in life do you really want to get heart failure.
Yeah, no, and it's amazing that the BNP test is only $20. I didn't realize that, and it seems like there should be a statement about maybe screening everyone who has either obesity, hypertension, or other pre-heart failure
The
factors.
screening
And
was all adults. These were primary care practices where you didn't require anything else to identify your risk
right,
other than
and
you were 40 and above.
but
Yeah,
like this, how we're
yeah.
promote an LP little a testing in everyone. There needs to be such a campaign perhaps regarding BNP, you know?
Yeah,
So,
and I think, you know, you could say anybody with type 2 diabetes, a high sensitivity troponin and a BNP, Ambarish Pandey, the Watch DM score that integrated this, you know, you got these gradations, you make SGLT2 inhibitors, even at branded price, so much more cost effective. So there, I completely agree. There's a lot of things we can do proactively to embed a systematic population level type of approach to identify those at risk and to apply these treatments.
wonderful. Other questions?
Outstanding presentation, Greg. That was terrific. So, couple questions. One, in the patients who have, I mean, your slide at the end would basically show that our 2021 mortality was very similar to that of 19. That's just astounding because we have so many new medicines that are out now for treatment of heart failure. We know we have the sacubitril, valsartan. We have lots of different things, and they're coming out with more and more and more drugs. And it seems like we have more tools available. But I wanted to get your thoughts on, you know, the trials that you presented in the terms of lowering the blood pressure, which will be done by any of these agents. Are those the primary drivers of these mortality benefits? And then second question would be, in your Jupiter trial and the other trial, which showed that you have a lipid benefit. So if you lower your lipids, you reduce your risk of heart failure. Do you think that lipid lowering is reducing your risk of cardiovascular events, therefore then reducing your heart failure? Or is it independent of your ejection fraction that when you lower your lipids, you can lower your risk of heart failure?
Yeah, great questions. So first, I'll start with, you know, why in this era that we have so many drugs that we think, you know, are working. And we actually know in our trials, when we apply sequential drugs, we get these marked benefits. So in clinical trials, in the placebo arm, where background therapy is kept improving, mortality has fallen and heart failure reduced EF by 70, 75%. In heart failure centers, where you systematically apply these drugs, mortality has fallen. We published it, others. But in clinical practice across the country, we've not seen the reduction in mortality. You say, why? Well, the simple answer is because most patients aren't on the drugs. You know, the year after sacubitril valsartan was class 1 in the guidelines, it was less than 6% of patients were treated. When you look at SGLT2 inhibitors, we've been publishing, you know, extensively on this. You know, it's about 1 in 5. When we look at quadruple therapy, you know, it's 10% of eligible patients in the US in 2024. Perfectly eligible prescription drug coverage that are treated currently with quadruple therapy. We do a horrible job of translating, you know, our guidelines into clinical practice. And even when treated, they're on the low starting dose and we're not up titrated. So we have a dosing gap. So a lot of what explains why there's great efficacy and great effectiveness when patients are treated according to the guidelines, the vast majority aren't. And it's complex. Why? And it's not just cost, it's inertia, it's all of those things. So we need to overcome it. How those drugs protect the heart, there are multiple non-overlapping mechanisms, neurohormonal deleterious effects, and, you know, so on and so forth. It's not the hemodynamic effects. They work regardless of blood pressure. And when you start them, they tend to, you know, they lower blood pressure in those hypertensive, but in normal tensive heart failure patients, there's really no change in blood pressure. It starts going up because ventricular function is improving. Now, the issue of statins and preventing event, most of it, people started to hypothesize maybe statins could treat heart failure, right, and treat LV dysfunction, but those trials did not work. Statins were neutral. They prevented atherothrombotic events, but don't restore LV function despite some basic science data. So in trials like Jupiter, primary prevention trials, secondary prevention trials, that statin benefit is plaque stabilization and preventing recurrent events. Now, not all those events are symptomatic. So when we're following patients, they didn't have an MI, but they had a subclinical MI. So the benefits of statins there are the less atherothrombotic events. People thought maybe they help for hypertrophy or hypertrophic cardiomyopathy. none of that borne out. So there's no harm on the myocardium. Some people speculated lower coenzyme Q10 and would worsen cardiac function. That doesn't occur, but it's through plaque stabilization and treatment. Now for hypertension, obviously blocking LVH and the remarkable heart failure reductions there. And the heart failure reduced is less heart failure reduced DF, heart failure preserved DF being reduced there. And a lot more of it is that heart failure preserved DF where, hypertension is a major, major driver.
Other questions from anyone?
Yeah, so I have a question from Dr. Mata. In the pathogenesis of heart failure with preserved ejection fraction, is the condition primarily driven by coronary microvascular dysfunction, myocardial fibrosis, or pathological substance deposition, i.e. amyloid or something else?
So great question. And what I would say, what we've come to realize, so much of this is cardiometabolic renal. And so obesity is a major driver here. So much of the heart failure preserved DF is driven by that and diabetes. So microvascular dysfunction is part of it, but there's myocardial dysfunction that occurs, stiffening in the heart, fibrosis that is driven by this. There's role of aldosterone in this, so why finerenone has proven to be beneficial in heart failure, mildly reduced and preserved DF. GLP-1 agonists, I showed you those event reductions. The SGLT2 inhibitors mark reduction. They're working through a multitude of mechanisms. So, complex pathophysiology, but so much of this tracks the kind of obesity-mediated inflammation, chronic inflammation being a major driver of heart failure with preserved ejection fraction. And so we can prevent it and we can actually now treat it. And you see, there's so few individuals presenting with heart failure now where healthy body weight or under, reduced body weight. So much of it is obesity and, elevated body weight. So that's the major driver in our understanding of pathophysiology. Now, there are specific etiologies, right? Hypertrophic cardiomyopathy, amyloid, those are really important. They have specific treatments. So I don't mean to downplay that, but the majority of our heart failure preserved DF, when you remove those, it's being driven by that diabetes, by obesity, by hypertension.
Excellent. Everyone, Dr. Fonner was one of the nation's expert in heart failure, so don't be shy. Ask her questions if you have them. This is a great opportunity to do so.
I'll ask you another question if I may. So the GLP-1 receptor agonists, certainly presumably are being targeted more for HFpEF, but is there any evidence that it may, help prevent or treat HFrEF this as well?
So this is a gap in our knowledge. There was this original FIGHT trial way back when that was acute heart failure and gave GLP-1 small numbers, but the events were heading the wrong direction. Heart rate tends to go up a few beats per minute, and that scared people off. So the trials were not looking at heart failure reduced DF. There is now interest. We need specific prospective randomized trials. There's a lot of indirect data that's kind of people look back at, well, some people got into SELECT that had reduced DF or some of these other trials, and maybe they're hints, but we need prospective data to know for sure. But looks promising, and there is, a lot of individuals with BMI above 30 with heart failure with reduced DF, but we'll need directed prospective randomized trials. Those are underway. So I wouldn't, for somebody who otherwise has indications, would not shy away from it, but would not specifically just be treating by virtue of the heart failure reduced DF. The other thing we wonder, well, what about heart failure preserved DF where your BMI is below 27? Are those individuals that we could effectively treat and get benefit? We need some specific trials there as well. There's some hints, maybe not, but we'll have to actually prospectively test it. There's certainly evidence in obesity. You're seeing benefits earlier and out of proportion to the degree of weight loss. You're seeing marked reduction in HSCRP. So, favorable effects on renal function over time. So there's a lot of intriguing mechanisms that may go beyond, in their receptors on the heart and otherwise. So may go beyond what we traditionally think, oh, it's all just weight loss. But that will be exciting to emerge. But in the meantime, think of how many individuals we have now with obesity and other risk factors that we should be treating with these drugs that are not yet treated. So we've got huge implementation gap there. I do see one other question in the chat that I do want to answer, and that is there any role or data that supports AI-driven heart failure risk prediction? And I do want to highlight when there's emerging data, you can take a single lead from the EKG and apply AI and detect the risk of future heart failure. So Rowan Curran and others have shown that you can do this from an EKG, even a single lead, and that could be adaptable to wearables. So, your single lead coming from your Apple Watch or other wearables. And so that may be a way that we can actually, a further way of alerting beyond a biomarker, use these digital markers to identify individuals at risk and then run additional testing on them and then make decisions about risk
Yeah.
factor
And,
modifications.
and
I'm
on,
excited about that.
yeah, and on that note, Greg, I might mention that we have some data, so some of which is already published, where we're able to measure LV sizes from CT scans, and we're finding that predicts heart failure just as well as MRI. So there's a lot to come with opportunistic testing, and maybe also from CT scans done for other reasons. We're going to be able to have very powerful data on predicting heart failure, atrial fibrillation, and other cardiovascular conditions. So we're at the top of the hour, but if anybody has any last minute questions, this is your chance. Just please unmute yourself and ask.
So the other question I would have, so going on that same topic of BNP, would you recommend BNP screening on just patients? Because picking up a heart failure with preserved ejection fraction is a tough thing to do. I mean, we have some tests when patients present in the hospital with it, but would you suggest getting BNPs on people who are at risk, maybe patients with hypertension, and then start treating them as heart failure preserved ejection fraction, or do a full workup to see if they do have HPEF?
Yeah, it's a great question. I think, the issue of whether there's symptoms or not, or symptoms that are subclinical because the patient has it, they stop going upstairs because they got short of breath, and you ask them, do you get any dyspnea exertion? They say no. So more detailed history and physical, but yes, in other words, I do think the use of these biomarkers as part of our routine assessment of risk, in the same way that we think of our lipid panel, the way we think of of blood pressure and checking them in is vital information, that this can be very, very helpful to think about. Now, obviously, there'll be times like you're going to get an elevated test and it's going to do this workup, and their echo is going to look normal. You're not going to have that full explanation, but you'll recognize there's some risk in needing heightened alert. So I do think you can make a very good case, including informal Markov models of cost effectiveness, of that this plays out, because these preventative therapies, when we're talking about ACE inhibitor or ARBs being applied, so inexpensive, you prevent that heart failure, those hospitalizations, $10,000-$15,000 a shot, you could cover a lot, thousands of people getting screened with biomarkers if you can detect a few that are at risk for heart failure and prevent that. So there's a good case. It's a different mindset, but again, that's where those prevention guidelines coming out and building that mindset of the way we think about preventing atherosclerosis, we need to think about preventing heart failure with that same level of urgency, and have in our mind all of these heart failure deaths that are occurring. We've made progress. You know, nobody's showing you the risk of MI and cardiovascular deaths in 1999 and 2024 are the same. No, they've continued to fall. We argue maybe there's a little flattening out, but nowhere where there's been a reversal like this. So a lot more can be done.
Well, I think with that, Greg, you've really shared with us a plethora of great information tonight, and thank you again on behalf of Dr. Baker and I, and also want to thank our participants for sticking to the end. And any final words, John?
No, I think that was an outstanding presentation, Dr. Farner. I think it's very clinically relevant. You know, we have so many heart failure patients that it's this is the time that we can start doing major things to help prevent patients from getting these horrible diseases. So thank you very much for your presentation. Thanks for the participants. We will have our next webinar on this. We have our webinars every second Wednesday of the month. Our next one's going to be on exercise in prevention of heart failure. So feel free to join, and we'd love to see you again. And again, thank you, Dr. Farnrow. Thank you, Dr. Wong, for an excellent presentation.
Thanks, everybody.
Thank you all. Have a great rest of your evening and week.
Mhm.